Good afternoon, everyone. Let's go ahead and get started. My name is Matt McDonough, and I am with the ESRD NCC National Coordinating Center. Thanks for joining us for today's ESRD NCC Provider Education Webinar event. Now, as you know, these events are held in partnership with the Centers for Medicare and Medicaid Services, and this series of events features guest speakers from around the country sharing how they, or the organizations they're with, are coping with COVID-19. Now, before we get started, I wanted to let you know that this call is being recorded, and we'll post this to our NCC COVID webpage within 3 business days usually. Now, truthfully, we usually have that recording up on the webpage in about 24 to 36 hours. So let's go ahead and we'll take a look at the agenda for today's call. Today, we are happy to have Faith Lynch with us. She's from the Acute Dialysis Department at NYU Langone Health. Our topic today is challenges in an ever-changing acute dialysis setting during a pandemic. Now, during our presentation today, if you have any questions at any time during the presentation, please submit them to us using the WebEx chat panel or the Q&A panel on your screen. When we get to the Q&A section of this presentation, we'll share the questions we've received with our speaker. Now, our goal, as always, is to answer as many questions as we can as time allows, and we'll do that up until the conclusion of our event. So let's talk a little bit about what this call is about. This is a series of calls that is intended to provide attendees with learning opportunities related to COVID-19. Now, as part of that, we share some real-world experiences on a variety of topics that you can hopefully put to use in your own day-to-day practices. So let's go ahead and begin our presentation. I would like to introduce Faith Lynch, who's a registered nurse who holds a master's degree in nursing leadership. Now, she's the clinical nurse manager for acute dialysis at NYU Winthrop Hospital. She's worked in nephrology nursing for 15 years in many different roles and has experience with patients with acute kidney injury as well as end-stage renal disease. Now, Faith is very active in the American Nephrology Nurses Association on both the local and the national level. She currently holds the Acute Care Specialty Practice Network Leader position, as well as the chapter president for Long Island. Faith is passionate about nephrology nursing and continuing education, which is why she's currently pursuing her Doctor of Nursing Practice degree at Chamberlain University School of Nursing. Faith, thanks for joining us today. Welcome to our call.
Thank you so much, Matt. So I'm going to start off by letting you know I chose the topic challenges in an ever-changing acute dialysis setting during a pandemic only because for us in New York, I can tell you that the acute dialysis setting really did change every single day here, especially in March and April. So that's why I really wanted to bring my story to the forefront so that other people can realize what we went through here and maybe we can help other units across the country with what we learned. Next slide. So I just want to disclose that I'm a full-time employee of NYU Langone Health, and I'm also a nurse consultant for Pentec Health and Outset Medical. And I also want to start off by thanking the ESRD NCC for allowing me to present this topic in partnership with the American Nephrology Nurses Association. So acute dialysis, it really means a lot to me, so anytime I get to speak on behalf of acute dialysis nurses, especially during the COVID pandemic and what everyone went through, I really take the opportunity and I run with it. Next slide. So the objectives that we're going to discuss today are an acute dialysis nurse's point of view and perspective on what the acute dialysis setting has gone through during COVID, which will then lead into some CDC recommendations that have been implemented for the acute dialysis setting specifically. And then I'm going to provide some ideas and strategies that should be put into place for future surges because that seems to be a large focal point. Next slide. So I want to start this talk off with a brief overview of risk factors when it comes to chronic kidney disease and COVID-19. I find this very interesting, as you'll see, because there are just so many similarities when it comes to both chronic kidney disease and COVID, and how in conjunction, this makes the renal population that we take care of such a high-risk population in so many ways. Next slide. So I'm going to be presenting a lot of information that the CDC has given us to kind of bring together all of the issues that we are still being surrounded with when it comes to the acute dialysis setting. but I really want everyone to start off by looking at this slide that's called Factors That Increase Your Risk for CKD. And you'll understand it more when I move on to the next slide, but these are just some of the risk factors that increase your risk for chronic kidney disease. You have diabetes, high blood pressure, cardiovascular disease, smoking, obesity, being of African American, Native American, Asian American descent, family history of kidney disease, abnormal kidney structure and function, older age. Just so you guys know, these are just the most common causes of CKD. Next slide. So what do you see? So I want everyone to really look at this updated high-risk medical conditions that are more so affected by this virus. Because as you can see, I highlighted our main population, which is chronic kidney disease in red, and this is obviously our main focus. But when you think about it, most patients with CKD have almost 75% of the high-risk medical conditions on this list. A big one is diabetes, and as we know, diabetes is the #1 cause of kidney failure in the United States. Our patients are immunocompromised, and I know that this states from an organ transplant point of view, but this population that we do serve is really considered immunocompromised. And then you have COPD, heart failure, coronary artery disease, cardiomyopathy, and a lot of our population have heart conditions, so due to, just say, for comorbidities related to CKD and diabetes. So they have calcified valves. Therefore, they need valve replacement. So they come into the hospital for TAVRs. It's just a rolling effect when it comes to these medical conditions. And a good portion of our population is obese. You have a high population of the African American population that has sickle cell. And it just kind of shows that our population is at high risk overall. So when you think of COVID-19, you need to know that the CKD, ESRD dialysis population is very much at risk. And I can tell you, we did not know this in March when it hit the New York area, but I'll get more into that later. Next slide. So this graph I took from the CDC website. It's specifically COVID-net, which is the area that's tracking all the positive cases across the country. And it kind of shows you a clear picture as to the population that's most affected during this pandemic. And that's the 65 and older population. And then next you have the 50 to 64-year-old range. And I could say as a nurse in the acute dialysis setting that those two age groups are where we start about 65% of our new starts to hemodialysis in the hospital. And this slide I really just kind of added as a little bit of a visual for you guys, and also another way for you to identify and understand how severe the population we serve is affected by this, because many patients don't realize that they have CKD. So a lot of these patients that are getting sick could have had underlying kidney issues that they didn't really know of. Next slide. So this next portion, I'm going to get into what the acute dialysis unit went through during COVID and how we dealt with it, because it's specific to my unit. And I can speak for most acute dialysis nurses, or really any nurse in general, that these times were dark and trying and really just downright exhausting. So next slide. So I titled this slide, Ready, Set, Go, because that is truly what it felt like. It was a blink of an eye, and everyone really needed their running shoes. So I'm going to backtrack a little bit. So COVID kind of took over in Washington State in late February, and then it made its way to New York rather quickly. I was actually coming back from my Disney vacation. So I'm on Long Island, and the hospital that I currently work in was the first to have a positive case on March 5th. So this patient was not a dialysis patient, but after that, it really kind of was all downhill from there. What felt like hours, but really only was a few short days. We had 45 hemodialysis patients that were COVID positive in my hospital, and they were a mix of chronic and AKI. And that's a lot for us at one time, and that didn't even include patients on, CRRT and PD. So in general, before you knew it, crisis planning was occurring. The ER had tents put up for triage. Every hospital room was made negative pressure. The basement conference rooms were turned into ICUs because we really didn't know what was coming. And then the first week, we had one COVID unit full, so they made one floor of the hospital COVID unit. And that in itself was daunting. Nobody wanted to go to that unit. It was scary. It was really fear of the unknown. But little did we know the hospital would be, I think, 85% COVID positive within 2 weeks. And this is a 591-bed hospital. And they added, I think, 100 more beds overall, knowing that they were going to be so inundated with these patients. And I can tell you, if a bed could fit there, there was one. And every procedural area, cath lab, endoscopy, all became open ICUs. But then on April 21st, we discharged our 750th COVID patient, and that was a big celebration. You know, news crews were everywhere. So it was nice to see the positive side on top of all the negative that you were seeing. But I really just wanted to kind of show you that we had 48 days in between to get there, but it actually really felt like months. Next slide. So during this pandemic, I can say staff in the acute dialysis units, we've kind of been learning as we go. So just to give you a quick overview, the role of our unit is to take care of patients with ESRD or AKI, and a lot of acute units vary in what they do. Some hospital acute units perform all extracorporeal therapies, but the nephrology nurses in my hospital perform hemodialysis only. So the ICU nurses perform CRRT with oversight from the acute dialysis unit. And then we have one main floor within the hospital that those nurses are trained in PD, and that's what they do, which is a huge help for us because, like I said, you know, in many hospitals, the acute dialysis program performs all of those therapies. The average inpatient unit size varies, but when I did some research, most are between 6 to 8 beds. Ours is 6. Some have an isolation room, some do not. We do not have an isolation room in our unit, which caused a little bit of an issue for this pandemic, but I'll get into that later. And just to give you another little bit of an overview, we do approximately 4,100 treatments per year. 20 to 25% of that is bedside normally, which is the ICU, or on the floors due to isolation. And the other 70 to 75% is done in the actual unit. So I want you guys to keep those percentages in mind. Next slide. So an acute dialysis nurse experience. So caring for these patients with COVID-19 in the acute setting, I can say was an experience that I will never forget. Predictable is not a term that goes with it by any means, and anyone in dialysis knows that, especially in the acute unit, everything is unpredictable. So of the critically ill population, and I want to stress that point, critically ill, not the average person, we're talking mainly about patients with underlying conditions. Approximately 25 to 40% of those patients developed AKI. And these patients came in with symptoms of volume depletion from vomiting, diarrhea, fevers, and then they would have severe sudden acute kidney injury with life-threatening hyperkalemia. Their potassium levels were going so high so fast that we didn't even know what was causing it, and all we could do was try and correct it as fast as we could with dialysis. But we noticed that the events took place in a sequence. So we noticed that these patients were having cytokine storms, which, as we know, can destroy kidney tissue. And then they would have the kidney failure, followed by the hyperkalemia. And we're not even talking about your typical ESRD patient that lives at a 6.2 potassium. We're talking about AKI patients with a life-threatening potassium of 8.9 and above with cardiac changes. And the hyperkalemia we noticed was occurring peri-intubation, and that these patients would be doing well, and then boom, they just seemed to crash, and then before you knew it, they were being intubated within 24 hours. And as time went on, you know, we saw more and more similarities between these patients, and we were able to kind of formulate a pattern, and you can kind of figure what was coming next. And we noticed that kidney failure symptoms took a sudden turn between the 8 to 10 day mark. So that's what we noticed. So we utilized multiple modalities. We utilized hemodialysis, continuous renal replacement therapy, and acute peritoneal dialysis. My hospital is not big on acute PD starts, but we had to do a few cases of that during COVID, and it actually really was successful. So I'm hoping to see that in the future, especially if anyone's listening, that we do more of that in this hospital. But I know a lot of areas we're definitely doing more acute PD starts. The mortality rate was initially above 90% the first 2 weeks, but then it dropped to about 60 to 70%, which is not great, but I think everyone really did the best that they could given the circumstances surrounding it. But I know the rates have dropped around the country, which is really great to hear. And then the big question, how did these patients tolerate dialysis? I'm going to say not good. They were hypotensive, on multiple pressors for blood pressure support, and that didn't even help. And now they were volume overloaded. So fluid status became an issue in the critically ill population because they were loading them up with fluid, so they're on 3 to 4 drips, which over 24 hours is a lot of fluid. And then you add AKI, minimal urine output, and then now the patient's fluid overloaded. So it was really difficult for us to find the balance to make sure that these patients didn't go from, dehydration upon admission to fluid overloaded in days, because at that point you're now running into other problems. And these patients had a really difficult time transitioning from intermittent HD from CRRT. So we tried numerous times to transition a lot of these patients off of CRRT, and they just were not stable enough because CRRT, as we know, is much slower and it's continuous and it's easier on the body, where IHD is not. It's made to remove fluid and clean blood in a quicker fashion, and these patients really just couldn't handle it. So, but also the severity of these symptoms that these patients were experiencing, it really warrants the involvement of staff that are specifically trained in nephrology, because it really increases their chances of a better outcome. And I say this strongly because I really believe it, but hemodynamic stability is seen completely different through the lens of a dialysis or a nephrology nurse and a nephrologist. It's what we deal with on a daily basis. I mean, a dialysis nurse in the acute setting can take a look at a set of vitals, look at a cardiac monitor, and they'll know if that patient's going to be able to tolerate hemodialysis. The ability of hemodialysis to impact the patient's hemodynamic status is very underappreciated, except from dialysis nurses and nephrologists and PCTs. So our acute care nephrology nurses are able to troubleshoot and gauge a lot of what these patients are going to tolerate, and we work so closely with the nephrologist that, we can almost tell them immediately, okay, this patient is not going to tolerate hemo, and suggest them to start CRRT. And that's where our skill set really comes in, and we're astute at recognizing the best modalities for these patients in conjunction with the nephrologist and working as a team. Next slide. So COVID-19 and AKI. It was noted to be highly complex, which many of us realize at this point. You had a tendency to cause blood clots, so research suggested that COVID actually caused tiny blood clots, and it formed in the bloodstream, and it actually clogged, from what I read, like small blood vessels in the kidneys and impaired its function. And then you had the wonderful cytokine storms, which is the active mediators of inflammation. And when that happens, the immune system kind of gets overloaded by the rush of cytokines into the body, but the large influx of the cytokines actually cause severe inflammation. So in trying to fight off the virus, this reaction actually can destroy healthy tissues of the kidney. And then you had possible invasion of kidneys by coronavirus. So I know many nephrologists, and some of them that I work with as well, were saying that on the biopsies, they were seeing that there were COVID particles appearing directly on the kidneys. And I know that this has been reported, and they're doing a lot of research on that, but it's actually proving that this virus is actively attacking the healthy kidney tissue. So the fact that this virus can and is potentially damaging the kidneys, it's very concerning. So all of these complex issues with AKI spiraled when you were trying to take care of them from a nurse point of view. So for example, you have a patient with hyperkalemia. You need to emergently dialyze them. You get to these patients, they're either clotting their circuits from this tendency to form these blood clots, and then you also had a lot of temporary catheters because these patients were not going to the OR for perm caps or fistulas or any of that, so they weren't working due to the viscosity of the blood. So it really was a ripple effect for all involved. Next slide. So what changed with COVID in the acute dialysis setting? So a lot of things changed when COVID hit. So our volume of AKI went up, which incorporates a lot of new starts to dialysis. Our bedside dialysis increased to 95%. That was the kicker for us because most acute dialysis units are not staffed operationally to do so many bedsides. So we have a 1-to-1 ratio, say for the month of April, for 365 cases. Now that's 1,277 hours of dialysis, and I have 11 nurses. It's a lot. And then the staff started to contract COVID and they became ill, which means they were out for a few weeks at a time. And then there were also no guidelines for the acute setting yet when it came to COVID. So we were kind of just guessing best practice based off of our knowledge. Next slide. So as a nephrology nurse and a manager, I had multiple thoughts going through my head at one time, and I say this because, we went from one COVID patient that needed dialysis to 45 patients in a few days, and I think we maxed out at 30 to 35 bedsides in one day, and our average is like 15 patients on a daily basis, so that was a big difference for us because it was really more than double. And then, equipment was in question. Turning over machines in a hospital is not easy, especially when, you need a portable RO and then a dialysis machine, and the nurses have to go from one side of the hospital to the other. And we had a decent amount of equipment, but we were running into the issues that since we were dialyzing in areas of the hospital that we normally didn't dialyze in, our equipment was not fitting in the rooms with these patients. So we really struggled, and we kind of had to come up with other solutions. And then you have allocation of dialysis supplies, which I'm going to get into on the next two slides. And then you have staffing and volume of patients, which kind of go hand in hand. Staffing was a huge concern. I didn't know how we were going to get these endless days done. I mean, how much overtime can one nurse do without becoming fatigued? We needed traveler nurses, and it took a good few weeks to get them. But dialysis traveler nurses are very hard to come by. And at that point, you needed somebody that was a plug and play. You did not have time to teach somebody a new machine. There was just no way. But we also did pull nurses from our chronic unit within our network that had acute experience, which was a huge help. And, the staff was working daily. Everyone pitched in, and the teamwork, it really did show. And then you have exposure. Exposure to COVID was big on our list because many of my nurses were so concerned, as was myself, because we didn't want to bring this home to our families. And the concerns were extremely valid. You're in such close proximity to these patients for hours at a time. So with the heavy load of patients and not enough time in our day, my medical director had to cut patient treatment times to 2.5 hours if the patients were stable, just to decrease nurse exposure and for us to get through these days. And then PPE, every hospital was low on PPE, but I have to say we were able to get the PPE we needed. We did have to reuse, but we were able to get it. And then water hookups. As we know, dialysis needs water hookups. There's nothing like needing to dialyze a patient urgently, and you get there and you cannot hook up the machine. So once we saw the increase, we quickly had our engineering department put water hookups on every sink in the hospital so that we did not have an issue. We still had issues with them disappearing, but for the most part, it was done, and it was a big job because we didn't dialyze in every single room across the hospital on a normal. We only dialyzed in specific areas. And it, wasn't like they could do it over time. They needed to get these water hookups on while the hospital, was filling up rather quickly with these patients. So, next slide. All right, so I know everyone wants to hear about CRRT. So, CRRT was at an all-time high to the point that we were rotating these patients 12 hours on, 12 hours off, just to give every single patient a fighting chance. I mean, we also had to purchase, I think we purchased 6 more CRRT machines that came sporadically throughout our COVID crisis, but in the long run, we're ready for a surge with more machines. So I'm sure that a lot of areas saw what New York was hit with in the beginning, so I'm sure they started ordering more machines. But the hospital did make the decision to purchase the Tablo dialysis machines by Outset Medical because they use dialysate instead of bag solutions for extended therapies. So if the solutions were going to be a problem, we needed to have another way. And they were small and able to fit, they were compact and able to fit in the 4-bedded rooms where we wanted to cohort these patients. And worst case scenario, because they're so simple, we were able to do walk-away sleds if we had to. And then the main issue that we had with supplies was more related to CRRT. That was the cartridges. The cartridges were clotting, the ICUs were rotating patients on and off, and we ran out. But we were lucky enough to, my boss was able to borrow from a neighboring hospital, which was great, which is why it's always good to network for those reasons. So now I think all of us know what machines every hospital in the area has. But I have to say the companies really did work together to get all of, every hospital the supplies that they needed. And then CRRT solutions, we thankfully did not run out. We were very, very close. But I know my medical director and pharmacy kind of had a backup plan in place where the pharmacy would manually mix CRRT solutions if we did end up running out. But we didn't have any issues with hemodialysis machines in general. Next slide. So in the beginning, there was so much back and forth and changes to which masks to wear. Is it droplet? Is it airborne? And every day was something new. So myself and my nursing director went down to the nursing office to ask for N95s because none of my nurses were comfortable wearing a surgical mask and a shield for 4 hours in a closed room. And I have to say, I understand because I was dialyzing patients myself, and we are very fortunate that our institution agreed and they understood our concerns. But listening to other, nurses on these forums, they were not as fortunate. But now, that leads me to my favorite CDC recommendation for the acute setting, which, quote, states, facilities should consider prioritizing respirators for fit-tested dialysis staff who spend several hours in a patient's room during a dialysis treatment with the door closed. When that came out, I knew we were safe because when the CDC recommends something, it's really in your best interest to follow that guideline. And you have to think, in every hospital, maybe there's 10 to 15 dialysis nurses. That's peanuts compared to other units. So I would think 10 to 15 N95s shouldn't be that bad to give out. And the N95s we used for 1 week. The gowns seem to be more the problem. I feel like with anything, they wanted us to reuse those if possible, but it's kind of hard when you're dealing with blood and bodily fluids to reuse a gown. But before you knew it, the nurses right now are kind of wearing garbage bags. Like, that's what they look like. But, who cares? It protects our clothes, and that's really all that matters. But shields, 1 per month, unless they were foggy, that you couldn't see out of them anymore from bleaching them so much. And then surgical masks, we got 1 per week. And all of those were obviously changed if they were, soiled or if the N95s got, wet, and then we would change them. Next slide. So out of my 11 FTEs, I had 2 nurses contract COVID by April 1st, and I felt bad. They were really, really sick. And at that point, I think we were just all waiting for us to go down, because I remember saying to my medical director, I'm like, I don't know if you're going to have any dialysis nurses left by the end of the month to dialyze any of these patients, because my unit is so small and we're all on top of each other. But we were very fortunate that the rest of us did not get sick, and then my other 2 nurses did recover well, and they came back to work within 2 to 3 weeks. I did have 1 dialysis transporter contract COVID, and unfortunately, he did not make it. He had underlying conditions, and I think it really hit home for us because he was a huge loss, great guy, and he's very missed. He had such a great relationship with our patients. And then I also had 1 nurse who was exempt from caring for COVID patients because she had underlying conditions. So she kind of stayed in the unit and dialyzed the non-COVIDs when we had them here and there. But during that time, it really wasn't that many, maybe 1 every few days. Next slide. So the acute dialysis role changed a lot during COVID. I feel like dialysis kind of does their thing and stays out of the way in most hospitals, but we really became a limited, valuable resource. I mean, you cannot teach a floor nurse to do dialysis in a day. You need weeks of training. You need to understand what you're doing. And I know that most people look at us like, oh, there they are, they just push buttons, but we know that there is just so much more to it than that. And dialysis is the one and only procedure that is ordered by a doctor, carried out by a nurse, without a physician present. So that really shows how important the nephrologist and the dialysis team working together really is, because it truly is a specialty. And acute dialysis in itself really kind of falls in between critical care and telemetry. So during this as well, we became mentors for floor nurses because they were all thrown into ICU after 6 hours of training. They never dealt with ventilators or multiple pressors for blood pressure support. They didn't deal with titration. You know, this was all new to them. And when we would go in to dialyze these patients, you know, we were able to say to them, hey, you need to increase the Levophed to so-and-so micrograms because I need a better blood pressure to maintain dialysis. Because we knew, even though we aren't ICU nurses, we still deal with ICU patients on a normal. So we were able to direct them and educate them on what we needed from them and really guide them for us when it came to dialysis. So we kind of really became mentors for them. And then we started triaging dialytic needs, you know, in a high acuity, high volume setting. It was something we really never had to do before. In conjunction with the nephrologist, you know, we were picking and choosing who needed to be dialyzed first, you know, especially with those patients with hyperkalemia. Next slide. So with all the questions and concerns we had in regard to what to do, are we doing this right, on July 7th, the CDC posted guidelines specific to the acute dialysis setting. And I remember doing a happy dance because I was on a conference call with my infection control department, my nursing director, and my medical director. And I just so happened to Google acute dialysis CDC COVID, and it was like fate. You know, the CDC posted this the day before. So it kind of helped answer our questions and concerns and helped us figure out the best practice for our ever-changing environment. Next slide. So the biggest concern and question that we had was, what do we do with these PUI patients, which is considered a patient under investigation, the patient that we were waiting for a COVID result on. So we didn't want to bring them to our unit because we were like 1 out of 2 units in the hospital that were not COVID units. So we were dialyzing all these patients bedside. So when we saw this, I was like, oh, okay. So the CDC, they do recommend that patients with suspected or confirmed COVID should ideally be performed in their hospital room with the door closed. And the reason being is that this limits the patient's movement within the hospital, which is a big deal because you don't want these patients leaving that room and like moving and spreading this around. And if the patient is to be dialyzed in the acute care dialysis unit, you need to consider using an isolation room. That's the second choice. But that's if you have an isolation room in your unit. If you do, hemodialysis should be performed in there with the door closed, but my unit and a lot of others don't have isolation rooms, which is why we chose to do these patients bedside. And also my unit is not negative pressure. So really, if they were COVID positive, they should be, well, at that time, they were considering it airborne. So they were like, you have to be in a negative pressure room. But then if you have a hepatitis B isolation room in your unit, you could only use that for COVID-19 patients if you didn't have any hepatitis B patients in the hospital. So if you had a hepatitis B patient in the hospital, you could not use that room for that. And then last but not least, cohorting patients was their third choice. So in a situation where there are so many patients, which is what we tried to do in 4-bedded rooms on the floors, was cohort these patients. So I could increase like 2-to-1, the ratio from 2-to-1. And then obviously any patient that's coming to the unit or being transported, they want masks on them at all times. Our patients are wearing face masks at all times, even in my unit now, so COVID or not. Next slide. So recommendations for dialysis staff caring for patients. So I already kind of told you guys that they did say that they should prioritize N95s for staff who spend several hours in a patient's room. And then they also said that the dialysis staff should limit time in the room with the patient, and that the facility should consider having dialysis staff observe and monitor the patient either through a window, a glass door, or utilizing a camera while keeping the door closed during the dialysis session. So if the dialysis staff are working from outside the room, the patient still has to be visible because you obviously don't want, any complications such as needle dislodgement or exsanguination. So a lot of the areas we were dialyzing in on the floors had no windows in our hospital, so we were unable to leave those rooms. So we did request these iPads on stands that they call telehealth carts, which allow us to visualize the patients on our work iPhones while outside of the room. We didn't get those yet, but that is part of our surge plan. Next slide. And what are the recommendations for cleaning and disinfecting the equipment? So I saw this a lot on some of the nursing forums as well. And according to the CDC, it's just current standards for routine cleaning and disinfection. Any surfaces or supplies or equipment located within 6 feet of a symptomatic patient should obviously be disinfected. Disposable medical supplies brought to the dialysis station should be discarded, and disinfect according to manufacturer's instructions and obviously your facility policies. But there was nothing, specific for COVID. Next slide. So there's definitely an aftermath of COVID when it comes to healthcare workers. We will see, I'm sure, a lot of depression and anxiety, and I know some articles have even stated possible PTSD depending on what people went through. So I can give you an example as to what I remember about COVID. I walked into a cath lab at one of my nurses to dialyze a patient. The cath lab was an ICU at the time. All the patients were prone on ventilators with multiple blood pressures, arrhythmias alarming on like 3 or 4 patients' cardiac monitors. People were running for defibrillators. And as a nephrology nurse, you're walking around and all you see are empty Foley bags. It kind of gives you chills. And then all you're hearing is, can you page nephrology, we need a consult. And it was very doom and gloom, and it was probably one of the saddest moments. And on top of that, these patients weren't allowed to have visitors. So, they were alone. So it brought a lot of sadness, and it's really a picture etched into my mind that I know I won't be able to get out. But I can only imagine what other people have gone through as well. Next slide. So stress on frontline workers is a topic that is so pertinent nowadays, and it's being discussed so much more now than ever before, as it should be. And the reason I say this is because we as healthcare professionals are caring for, even losing, not just patients, but family members, friends, and colleagues to COVID. And that can be both physically and mentally exhausting. So everyone in hotspots across the country were working double time, and getting the job done, which is impressive. But as time goes on, when you're dealing with so much death, and you don't see it getting any better, and you don't see any end in sight, I think it's very overwhelming. And some of the factors that are causing added stress are high turnover rate. This can be staff. They're getting sick, and then you're short-staffed, and then you're worried about them. And then you have nurses who are, leaving the field. They're retiring. They don't want to deal with this, and I understand that. And then this can also be patient turnover rate, patient volume, death in general, patients, families, friends, colleagues, long hours, which turns into exhaustion. Exhaustion is real, and I can tell you I felt it myself, dealing with it from March through May. I was working 16 to 17-hour days, 6 days a week. Sleeping was difficult because you had just racing thoughts, and you're working at such a high, fast-paced, stressful environment that your body almost doesn't know how to come down from the adrenaline that when you're trying to rest. And then you have anxiety. And that was for this was for so many reasons. A lot of it is about the safety of yourself and the safety of your families. Am I going to bring this home to my kids? Am I going to get my elderly parents and my grandparents sick? You know, no one wants that, and it's really a valid fear. Next slide. One of the biggest points to take from this is how important self-care is. And self-care is important for everyone while dealing with this pandemic, I think. And I don't think I realized how important self-care really was until this all started. And you need strategies to kind of shift your mindset, and that can be, you know, going from work to home, or just, you know, speaking to someone about what you're feeling. Exercising, they say, you know, helps relieve the stress, and it's a form of self-care. But in my institution, every single punch-in clock, there was this caregiver going home checklist, and that's kind of why I wanted to show you guys this. I really think it helps. It kind of almost made you feel like, okay, you know, it's time to shift the mindset, leave work at work. And I know for many of us that's really difficult because most people worry about everyone but themselves. And I just thought that this provided a positive message before walking out of the hospital every day. You know, acknowledge one thing that was difficult. Let it go. Consider 3 things that went well today. Be proud of the care that you gave. Checking on your colleagues, and then asking if you're okay. And then switching your attention to home and just resting and recharging. You know, it's telling you that your feelings are valid, but you also need to practice self-care. And this actually had a COVID crisis hotline number attached to it from the hospital, so that if people needed to talk, there was a lot of outlets made available to staff. Next slide. Resources for nephrology nurses. So this is so important because I think we all need resources and a place to be able to find information we need when we need it. And I have to say, ANA did that for their members. Next slide. Okay, so this is ANA's Nephrology Surge Support Tool. So it was developed as an initiative launched, I think, in April in response to the critical shortage of nephrology nurses. So it's kind of designed as an online interactive map, and it tracks the need for nephrology staff members. So that includes like nurses, patient care techs, social workers, all in different areas. And it connects the providers that have a need and like the providers who are willing to travel to provide assistance. So it works both ways, which is great. And I can say my hospital was on this surge tool because I think my medical director actually jumped on it and listed our hospital because I needed traveler nurses desperately. So it shows really that anyone can do it or utilize it. And I did get quite a few phone calls as well from other members that saw this that were willing to travel to help us out. And it also includes like certain travel resources, like hotel discounts, like where the members can kind of rely on to assist, like to make accommodations. So it truly is a beneficial tool. And if you haven't used it and you need to, you can find it on their website, which is listed on the screen. Oh, it's not on the screen. Okay. But it's www.ananurse.org. So next slide. So this slide is just a visual of ANA's website. I just kind of wanted everyone to see other resources that they made available to us. I could say the national office there, President Lillian Pryor, Executive Director Dr. Tammy here, and the Board of Directors really did an amazing job, and they still are, in making sure that all of us in the nephrology nursing world have up-to-date information. I mean, there's resources and education in regards to COVID. They have, you know, stuff on there for mental health, and they have surveys, and it's just a really great website that people should utilize, especially during these times. Next slide. So everyone learns from other people's experiences, which is where this next portion comes in, and it's titled Ideas and Strategies to be Prepared for Future Surges. Next slide. But I'm just going to go with how did we survive? So we survived on communication, relying on each other, support, knowledge, and the most important is teamwork. If you don't have teamwork, you really don't have anything, especially in this type of situation. The communication between the nephrologists, my medical director, and all the nurses was amazing. Everyone knew what was going on with everything, and it really made our day-to-day operations run as seamlessly as possible. I mean, you always have hiccups, but, once you figure them out, it gets better over time, and it can only make you better for the next time. And plus, a lot of coffee and snacks really did get us through, but I just wanted to add that in there. And then, next slide. So preparing for a surge. We all know a second surge is inevitable. Not saying it's going to be as bad as the first, but we know it's going to happen. So first things first, you need to have a plan. You need to sit down with your administration team and vet your concerns as to what went wrong, what went well, what issues you ran into, what issues you do not want to run into, so that you can kind of prioritize what needs to be done come your second surge or your first surge, and how to prepare for it. You need to order extra supplies. We started ordering more and keeping extra supplies in the warehouse because we didn't want to run into any issues. So I think you kind of always learn from your mistakes. And in this case, for us, it was really the unknown. And also, I know space is an issue in most acute dialysis units because it is in mine. So it's another reason why you need to have a plan. And then you want to invest in extra machines. If machine shortage was an issue, you need to purchase now, because if we all surge at the same time, you're not going to be able to get them, rent them, because we're all going to be trying to do the same thing. So you have to think of that as well. And then staffing. I think by now, hospitals really understand a little more as to how scarce, but how important dialysis staff is and how hard they are to come by. So our plan is to get traveler nurses earlier than before, like right when we see a surge, because we were a little bit later in the game due to the unknown, as if we were going to need them. Because honestly, hospitals were focusing on needing just ICU nurses. They didn't know they were going to need dialysis. So that's part of our surge plan. And then bed allocation. So we eventually started cohorting our stable COVID patients, like I said, in 4-bedded rooms, because I needed to bring the ratio for 2 patients to 1 nurse, due to volume and staffing. But I would suggest that you speak with your bed board in your hospitals and develop a plan as well, because once we had a discussion with ours, it became, a priority when we needed patients moved. We would say, okay, we need this patient moved quickly to ICU because we need to start CRRT. So that was a lot of moving parts for my medical director and the critical care nursing department, but they did get it done, and it took a while to get the process down because moving those patients wasn't easy, but it shows that, you really need a team effort in order to get things done. So, but I do hope you guys can take some of this, for those that don't have plans in place, and start working on how to make it better to prepare for the future. And I hope that my experience, along with input from my nurses, helps you to understand that some of our mistakes and uncertainties can really help other hospitals and dialysis units be better prepared. Next slide. And I'm going to leave you off with this quote: "Never doubt that a group of thoughtful, committed people can change the world. Indeed, it is the only thing that ever has. And remember, please always work together and just always thank each other for all their, all your hard work and dedication." And next slide, Matt. And thank you so much for giving me this opportunity to speak in regards to the ups and downs of the dialysis setting, and I hope you guys are able to take something from this. Thank you.
Faith, thank you so much for presenting today. And we do have about 5 or 6 minutes left for questions, so if you don't mind hanging around for about 5 more, I'd like to ask a few that we've received from our audience today. Our question number 1 came in. Well, first off, there was a request. There were numerous comments that the caregiver going home checklist is excellent, and requests if you were able to share that. I don't know if you could send that to us, and maybe we can publish that as part of our, when we archive this recording or whatnot. But just wanted to put that out there. There were many comments to that effect.
See, I'm so happy that was a hit.
Very much so, it appears. Another question: have you noticed an increase in CRRT startups on the older population that have had COVID?
So more so our CRRT startups, like in general, just during COVID, right? So during COVID, our CRRT startups were highest, I think, between the ages of 50 and 65. We had some in the 70s, some in the 80s, but Yeah, it was more the younger, I feel like 50 to 65.
Okay.
I mean, I could look up the data if they really want it.
Well, I think that's a pretty sufficient answer. Thank you.
All right.
Question on this one is, and this is more of an opinion, and this is from somebody in South Dakota who says their unit in Sioux Falls suffers from fatigue still. They've dialyzed so many patients, and they don't have the allocation for travel nurses like bigger hospitals do. They would like to know what your opinion is on, based on what you've shared today, on when we'll see the light of COVID, and your opinion on when we'll slow down. And I would lean to think that probably not soon, since we're talking about prepping again for another wave, but I'll let you chime in on that.
So I can say we died down from COVID in June. So, COVID dialysis patients. We just had our first COVID AKI literally this past weekend. So June, July, August, we actually haven't had many. So I'm sure everyone's going to see a light of day. I mean, I didn't think we were going to see one. It was a good 2.5 months of, constant. But if they're worried about staffing and all that kind of stuff, I would think cohorting those patients would be the best bet in that type of situation.
Very good. Very good. Thank you. Is there here's one. When CRRT is performed, is there a specific recommendation that you followed for disposing effluent from patients with suspected or with confirmed COVID-19 cases?
No. It was the same.
It was the same. Very good.
Yep.
Great. Did you have any specific or non-standard to your usual process discharge planning considerations for hemo patients with COVID-19 in your location?
So we're very fortunate that we have 3 chronic units attached to our hospital. So most of our COVID patients went to our large chronic dialysis unit that they were really kind of helping us get these patients out into the chronic unit, then leaving them in the hospital. So, I know it's kind of different from every area what they were doing with chronic dialysis COVID patients. I know some areas had just one specific unit for COVID. So it's a little different when you're dealing with a private hospital and their chronic units versus, an LDO.
Right. And that was actually, you just answered another question we had about a dedicated unit. So a good question just came in, and I actually, as I read it, I was like, that's a really good question to ask. Did you see, when you had acute kidney patients come in, did you see generally that they recovered, or due to COVID, did you find that a greater portion were turning to ESRD?
I can say a lot of our AKI patients really didn't do well, which did not really leave the hospital in the beginning. But the ones, a lot of them did not recover. They ended up ESRD.
Okay. All right.
And there is a lot of research on that these patients are not recovering.
Mm-hmm. Well, you had mentioned because of the damage to the kidney tissue that it seems like it would be not a helpful situation. Right. Does your facility provide pediatric hemo? And with COVID, I think COVID directly is the question, did you see any increase in pediatric patients, if so?
We do pediatric hemo very rarely, thank God, and we had 0 pediatric COVID patients on hemo during COVID.
Wow, very good. That's great to hear. I'm just making sure I don't ask the same question twice. We've scanned through here.
Fine.
Here's an interesting one, and I guess question 2 depends on the answer to question 1. You mentioned that your hospital is not big on acute PD starts. Now, is that in general, or was that just specifically related to COVID? And if so, do you identify?
That's just in general.
In general?
That's just in general. Yeah, we're just not an acute PD starting hospital. But we did do a few during COVID, so that's why I said I'm hoping that with the success of that, maybe they would do that a little bit more. Okay.
So it's not necessarily any barriers that exist. It's just not something that you've done historically, but maybe.
Yeah. I think it really depends on the nephrologist and their preferences as well. So.
I don't necessarily know. I'm going to ask this question as it was written, and hopefully you'll understand the question more than I do. With the Tableau machines, did you find that the clearance was okay with the decreased DFR?
Yes, we did URRs for a while on those.
Okay.
So we made sure that the clearances were good. Yes.
Great, thank you. We have 2 more questions, and we have time for about 2 more questions. So that actually works out great. Is there a preferred hemodialysis modality, intermittent hemo or CRRT, for patients with suspected or confirmed COVID-19? Did you have a preferred modality?
So I can say that I'm pretty sure ASN posted, when COVID came out, they posted that CRRT was the first choice in those type of patients. So we did a lot of CRRT. I think our CRRT tripled. I'm trying to think. I think we had like 70 patients on CRRT in the month of April. For us, that's a lot.
Right. Oh, all right. And our last question, and thank you in advance to everybody who asked for these great questions. This one says or asks, were you able to prevent the complication of poor running catheters or clotting catheters? This person asking says they had multiple COVID cases that ended up with 4 or 5 catheters due to clotting catheters.
No. We had the same problem here. It was a nightmare. No catheter worked because they were all temporary. The ORs weren't open, so we didn't get any good catheters. We just had all temporary catheters that just did not work. Because they were all clotting because the blood was so thick.
One just came in. One more last question. This should be a quick one. They asked, how many CRRT machines do you have? You said you got some more. How many do you have at your location?
We have 13 now.
Okay.
So we added 6 to our, I think we had 7 or 8, and then we added 6 more.
It's a pretty drastic increase during this time. So.
Yeah, my medical director does not mess around with CRRT.
Well, Faith, thank you so much for answering all those questions. We actually have run out of questions, and just in time because we're coming up on the conclusion. So I appreciate you being here and sharing with us today.
Thank you so much.
Great. And before we do end today's event, we'd like to tell you a little bit about the kidneyhub.org. This is our secure, mobile-friendly web tool for patients and professionals. It was developed by the NCC along with input from patients. As you can see on your screen, there are lots of important resources linked there. COVID-19, infection prevention, new ESRD patient education. There's been a whole bunch of new resources added. If you were on the beginning of the call, you see that we've added a slew of resources in each topic. If you haven't been there in a while, we invite you to go visit thekidneyhub.org from your mobile device. Take a look today and see what's new there for you. Our next COVID-19 webinar events are our patient-focused event is on November 3rd, and that's at 4 p.m. Eastern. And our next provider-focused event is on the 10th of November. That's at 3 p.m. Eastern. As with all our events, you can visit www.kidneycovidinfocenter.com for more information and to register. And by the way, we did get a question on where the recording for this event will be posted. If you take a look in the chat, we did post the link to the webpage where this recording and event will be archived within the next couple days. So that brings us to the conclusion of our event. On behalf of the NCC, I just want to thank you for attending. You can see our contact information on the screen here. If you have any questions about today's event or anything else we can help with, please don't hesitate to reach out to us. Additionally, the CASER Coalition and our kidneycovidinfocenter.com websites are listed here on this page if you're looking for any additional resources for COVID-19. Again, thanks for being here. We appreciate you spending some time with us today. We hope you found this informative. We hope to see you again on a future COVID webinar. Take care, everyone.